Welcome to our podcast, Psychiatric Services, From Pages to Practice. In this podcast, we highlight new research or columns published this month in the journal Psychiatric Services. I'm Lisa Dixon, editor of Psychiatric Services, and I'm here with podcast editor and my co-host, Josh Berezin. Hi, Josh.
Hi, Lisa.
Today, we are going to talk about two articles. We're really, changing it up. These articles, one is about the Project ECHO to increase medication-assisted treatment in rural primary care, and the second one is going to be talking about hurricanes, which is pretty timely since even as we speak, we're worried about a hurricane hitting Florida. So let's get started.
Great. First up, we have Julie Salvador and colleagues on engagement with Project ECHO to increase medication-assisted treatment in rural primary care. So we've actually talked about Project ECHO before in a previous podcast.
Yeah, how about that? Well, it's important. Project ECHO is an example of a way to bring care to more rural areas that have less in the way of mental health professionals.
Yeah, and when we were selecting articles for this month's podcast, I think that was one aspect of it that really drew our attention. But the other aspect was this really hits on a couple of interesting points. One is the opioid epidemic, which is obviously of major concern to everybody these days, but also about training and how you make training successful and providers be able to participate in it, which I know
Exactly. Yeah, I mean, it's training and implementation of evidence-based practices is something that I literally deal with every day because I run something called the Center for Practice Innovations. And it's so challenging and so important because we don't stop learning and we don't stop changing once we finish our training. And you have to think about that even at an agency level. So we'll talk a little bit about that as we go. But one of the subtexts for this discussion is going to be how to improve quality of care.
Right. And so specifically, they're talking about, again, the context here is the current opioid epidemic, particularly about the lack of medication-assisted treatment with buprenorphine in primary care. So as probably most of our listeners know, buprenorphine is an effective treatment for opioid use disorder, but it requires some training it actually requires a waiver in order to prescribe it, and so you have to get trained on how to use it properly. This is a brief report, and it focuses on New Mexico, which is the home of Project ECHO. It's also a rural state which has a drug and opioid overdose rate above the national average, but basically not enough people to prescribe buprenorphine.
Exactly, not enough prescribers. Right.
That's right. Or
can I just have this thing, like I want to be able to say what ECHO stands for? Because
yes.
I think that's something like everybody's going to want to know.
Well, coming right up.
Okay. ECHO. ECHO. ECHO.
That's right. And that stands for Extension for Community Healthcare Outcomes. And as we mentioned, that's a program that was developed by the University of New Mexico. The idea is that you have experts who are congregating in one place, and then non-experts are video conferencing in for both training and consultation. And the idea is that it's a very interactive training experience where people are presenting cases and getting feedback from the experts. So it's not just sort of like a one-way street.
Right, exactly. So that really speaks to this whole issue of what we know about effective training and implementation, that it can't just be lectures or it can't be exclusively lectures. And so this is information is provided, but learners have the opportunity to engage with and learn from in a very active way from the teachers.
Right. And so, as you mentioned, this study's primary focus is really about what helped and got in the way of these rural primary care providers participating in this project. Mm-hmm. So they designed a 12-session ECHO program around medication-assisted treatment. And then they did a lot of outreach to get primary care clinics around the state to sign up. Really cast a wide net across New Mexico. But to be eligible, a site had to have at least one prescriber who had less than 30 patients who they had prescribed buprenorphine to in the past 6 months.
Right. So we're talking about targeting people who can prescribe, but in some sense who are under prescribers, mm-hmm. right? So trying to support their prescription of medication-assisted treatment.
Right. And to look at the facilitators and barriers to participation, they tracked attendance, they looked at the number of participants who presented cases. They also contacted participants afterwards to find out why they had missed sessions, for example. And then at the end of the training cycle, they completed qualitative interviews to figure out more about why people may or may not have participated.
So in case our listeners hadn't realized this is not a randomized controlled trial.
No randomized controlled trials today.
But I think it's important to understand, really issues in the improvement of care. So that's why I'm happy with it.
As long as you're happy. That's what we're here for. So they had 24 participants, 13 were prescribers, and it was sort of interesting that 11 of them were staff at the clinics. They had almost half the people were non-prescribers, which I don't think the trainings were necessarily geared towards non-prescribers.
Well, but it's a team-based, all of this work is so team-based, and so I think it was actually sort of cool that the training was open to both prescribers and non-prescribers.
Yeah, and actually one of their findings was that when they had non-prescribers and prescribers participating, those clinics, it seemed to facilitate discussions around the prescribing of buprenorphine. But we're getting ahead of ourselves.
Right, okay.
The prescribers attended a mean number of 5.9 sessions out of the 12, and non-prescribers attended 2.6 sessions. So they have a figure showing the attendance at each session, and the first one is a little low, but then it kind of peaks at session 2 at around 90%, and then kind of slowly drops off by session 12.
Yeah, it's kind of a depressing graph.
But it does, tells a story.
It's the story, yeah.
And is that something that you obviously must experience that with the trainings that you implement?
Oh, no, not my training.
No drop off in Lisa Dixon's trainings. 0 drop off. It's 90% all the way through. You get a slight uptick at session 12. We'll put a graph of that on our.
That's when we pay them hundreds of dollars. No, we are laughing too much.
Okay, so when they asked people what their experiences were, people tended to like the ease of the video conferencing, the availability of experts, and then, again, like I said, kind of the galvanizing effect of introducing a medication-assisted treatment into their clinic. And their key finding is not one that's going to surprise very many people, but must be something that you encounter with training, is that the providers really felt like the biggest barrier was time. And not just time, but that to be successful, to be able to engage in this training, the leadership of the clinic really had to carve out the time and the resources to allow for participation.
I think this is a really important concept, just if we expand that whole issue of leadership supporting the clinic. We tend to think, as providers, well, we just have to do X and Y. But in fact, we live in community mental health. We live within systems and agencies and programs, and I think it's important to understand that the policies and procedures and regulations may have as much, if not more, impact on what we can do than our own skill set.
Mm-hmm. This is also very timely for me because I've, just to be honest, I've been putting off getting my waiver, but it's happening the middle of this month because the clinic where I work at is now requiring it, and they've set up the training for everybody. So,
well, there you go. So you have a real example of leadership support, right?
At least in the getting people to training.
Right.
And I think one of the other points here is that there's probably got to be some, maybe that they don't make in the paper, but I think there also has to be support for the follow-up as well, and how you're going to support the staff and
exactly. So this paper really focuses on the introductory or the early training for the clinicians, and you sort of have to worry that if the agencies don't provide a lot of support in the training, then what kind of support are they going to be providing in an ongoing way?
Yeah, and you can really see in the comments that people make about trying to balance clinical care with training, you can sort of feel people being pulled away from the training activities and into direct clinical care. There's always a fire to put out. It's not going to stop because you have an echo training going on. And so there's got to be some sort of countervailing force to keep people engaged in that.
Yeah, no, I think that's an important point. I think that in some sense that, the take home for this paper was fairly simple. It's a brief report, but here a huge clinical problem, a huge life problem, a huge life and death problem people dying from opioids, and a really well-conceived, organized approach to training clinicians in a state where it's needed. And what we see is really, fairly limited participation in the training, to the point where, one of the things the points I wanted to make here is that when we offer training, so if I'm Project ECHO or if I'm the Center for Practice Innovations, which I direct, we have an obligation also to see if our training is effective and to make ourselves accountable. But it's very difficult to do that when the uptake of the training is limited. And so then what one realizes, if you're a purveyor of this kind of training, is that your accountability in some sense doesn't start with session one of the training. It really has to start with creating, working with the training and working within the training environment to try to promote the conditions under which people can participate in training. And it's tough. It's very tough, because if the training entity is not organizationally part of the entity where people are being trained, you have this discrepancy or a divide. And so and then there are many creative solutions to this, but the point is here, I think, that training and improving practice is way more than just providing the training. So, simple study, a really, really important problem, and, one that I think many of our listeners can relate to and actually participate in problem solving. Providers, teachers, and agencies, at every level of the system, we have to engage around quality improvement and training.
Well, especially for an issue that's as large and important as the opioid epidemic.
Right.
If there's ever a time when we need to train up our workforce, it's right now. But it's not as easy as it sounds. Next up, we have Zelda Espinel and colleagues with an open forum entitled Forecast: Increasing Mental Health Consequences from Atlantic Hurricanes Throughout the 21st Century. So, like you said, a very timely open forum with the beginning of hurricane season and Hurricane Dorian bearing down on Florida as we record right now. Really, the article is about how psychiatrists and mental health professionals are going to respond to kind of the increasing burden of hurricanes as climate change makes hurricanes stronger, wetter, and slower, and dumping more rain.
I think just the issue or the prior is, before how psychiatrists are going to respond, is that these hurricanes have mental health consequences, and they're making that case here.
Right. I think I've probably in the past have had my own skepticism about, what is the role of psychiatry in climate change? I am way behind the curve.
Yeah.
There's a lot of advocacy and work, and I think over the past 10 years, I've definitely become convinced that we have to have a role, and the open forum makes a really good case as to why. Right.
And I think if any of our listeners have not educated or begun to educate themselves on the role of mental health, psychiatry, psychology, social work, all of us, and self-help and peer help. We all need to mobilize and understand that we need to be aware that there will be an impact, and we need to be ready to help. And so this, again, I can imagine that, if you haven't read or you haven't engaged in this article is a good first education on what we need to be doing and why.
Yeah, and I think one of their key points here is that hurricanes are kind of having two broad effects. One is that they can induce mental health issues in people who are affected by the storms, and then they have potentially grave effects for people who already have mental illness.
Yes. I found a very evocative phrase was this notion of each storm has a unique hazard profile, now I'm reading from the paper, and generates a singular, quote, trauma signature.
Yeah, and then the open forum, as you'll read, describes 5 different Atlantic hurricanes over the past three years or so, and really talks about how they each uniquely affected the area they hit, and the mental health system and the consequences there. I mean, for me, on this issue of affecting people who already have mental health issues, it just immediately brought back Hurricane Sandy here in New York City. I was in residency. I wasn't at Bellevue or NYU. And for those who don't remember, this was this major hurricane that hit New York City, and 3 major hospitals on the east side of Manhattan were evacuated, shut down, and all of their patients were dispersed across the system. So I was luckily on a medicine rotation at the VA, so I wasn't at Bellevue or NYU when all that was happening, but a lot of my colleagues were at Bellevue when the power went out and they had to evacuate. I mean, can you imagine evacuating hundreds of psychiatric inpatients while there's no power and there's no running water, or maintaining kind of safety on a unit when in those conditions and when there's a lot of chaos and communication issues?
It's just very difficult to even conceptualize.
From both ends, I am always like, oh, my co-residents, but of course, like, you think about what that's like for people who are on those inpatient units at the time. And then I think one of the other points of the paper is that there's both, like, when the storm hits, and then there's the aftermath, which was really when I kind of experienced these issues around how storms can affect the people who already have mental health issues. Mm-hmm. I did my sort of memory of one of my big memories of the aftermath of the storm is being stationed in the atrium of Bellevue. It was very cold. The heat wasn't on yet. And we were sort of this like table of the emergency department attendings and social workers who were taking basically walk-ins and then turning them out the door and giving them referrals to other places. So you can imagine that this major psychiatric emergency room was shut down and had to move. All those patients had to be absorbed by other parts of the system, and then people who were in clinic had to go find other places, and the whole system had to figure out where they're putting these people and how they're going to expand capacity in other hospitals. And for the rest of my residency, there would be this kind of trickle of people back into the Bellevue system who were kind of like storm refugees. They had been washed to a different system and were kind of slowly making their way back, and tremendously disruptive for people's treatment. Yeah.
So again, as the paper points out, and again, it's very concise and clear. Storms interrupt the daily routines of persons living with mental illness. They're uprooted during evacuation, as Josh has pointed out. And they clearly, experience disruptions in their care, disruptions in their medication, and, even who can even get there to deliver the care. And so you can have a situation, as the authors point out, where people may decompensate or just really have a difficult time managing. And then in terms of, the stresses and situation of people that, say, without previous mental disorders, the paper, again, really kind of points out that you have storm-associated trauma, loss, in terms of even connections, home, all people's material items, trauma, loss, adversities, and life changes. And one of the things that, again, they point out is that direct exposure to hurricane adversities is a well-documented risk for new-onset psychological distress and PTSD.
Yeah, and I mean, this section of the open forum made me think about stories that I had heard about people, I think it was in Harvey, where they were stranded and having medical emergencies and were calling 911 over and over and over again, and the emergency response system wasn't working anymore. And besides the loss of life that may have contributed to, just the amount of stress of like loss of control over a system that you think is going to work for you and you think is providing a safety net for you not being there and not functioning the way. And that's something that people experience every day. But on a storm, it's sort of like so concentrated. Yeah. Just that alone, I think, is just a vivid sort of example for me of what kinds of stressors these storms cause on such a massive scale.
Right. And I want to point out to people, to our listeners, that I just, you may have been a part of or experienced these hurricanes. It was Hurricane Harvey, Hurricane Irma, Hurricane Maria, Hurricanes Florence and Michael. So, I'm sure many of you lived through those and can relate to this. And I think there's really value in thinking about it and trying to say, okay, what did we learn and what could we have done differently? I think it might, before we close on this, it might be useful again to sort of review, at least in terms of the paper, what the paper says about how we should be prepared. And in particular, there's a focus on psychiatrists, but I don't think this is restricted to psychiatrists at all.
Both individuals and also the mental health system too.
Right. So what are the main points that the paper makes about what needs to happen?
Well, I think that they kind of divide it into, again, two sort of categories. One is preparing yourself, which is basic sort of disaster preparedness for yourself, your family.
Yeah, you can't take care of others if you're not taking care of yourself.
Right. And then the second one is really helping and serving a role in preparing the system. So this is kind of more of an advocacy position to work with local public health partners and figuring out how to minimize trauma exposure, maximize resilience. And it seems like it's an opportunity to kind of be creative in thinking through some of these issues with public health partners. They also put in a plug for getting involved with APA's Climate Psychiatry Caucus, who's been thinking about this issue for a bit now and have some materials and things to think about in this advocacy position.
Right. And I think that the paper refers to helping us figure out how we can even be helpful in real time when these things are happening. So we prepare, and part of preparation is creating opportunities and pathways for us to be helpful in the moment. Of course, assuming that, we've again taken care of our families and ourselves.
Right, and in the aftermath as well.
Exactly.
So that we can figure out how we can do this better, because climate change is, as they say, it's really going to make all of this more frequent and more intense.
Yeah.
So now's the time.
Yeah, and your comment makes me think about the fact that while the paper itself focuses on hurricanes, we can think of, this is horrible to think about, but it's real that, we have fires, we have other sort of acute and enduring environmental crises that we need to be at the table to think about and to try to reduce suffering. Well, that's it for this month's podcast. We invite you to visit our website, ps.psychiatryonline.org, to read the articles we discussed in this episode, as well as other great research. I also want to encourage everybody to explore our Editor's Choice collections. We just released one on early psychosis. Our next one is going to be on justice-involved patients. And we're very excited. I love to hear what people want us to create collections about and what you're thinking about how useful these collections are. We welcome your feedback. Please email us at psjournal@psych.org. And you can rate and review the podcast on iTunes, Stitcher, or wherever you listen to it. And I listen to enough podcasts to say, give us a good rating. I'm Lisa Dixon.
I'm Josh Bearson.
Thank you for listening. We'll talk to you next time.